Hello, welcome to Medical Immunology. Today's lecture is Receptor-Mediated Signaling. I'm Milton Greenberg. We will introduce receptor-mediated signaling from an immunopharmacology perspective, introducing NF-kappa B, nuclear factor kappa B, as a master regulator of inflammation, and discuss corticosteroids as a class of drugs to interrupt NF-kappa B signaling, inducing anti-inflammatory mechanisms. We'll also discuss dendritic cell activation by microbes and how these dendritic cells go on to activate T cells, which are the master regulator cell of the immune system. We'll discuss the different signals that are imparted from the dendritic cell to the T cell, and discuss the calcium signaling and calcium dynamics, and then also how this can be disrupted with calcineurin inhibitors. We'll also introduce CD28 and CTLA4 and checkpoint inhibitor immunotherapies as pro-inflammatory therapeutics. And then we'll also review the upcoming homework assignment that will be part of the quiz that will be coming later in the course. So just a quick overview and a quick review. A number of this was covered early in the class. I'm just going to kind of bring it back, make sure we're all on the same page. So the immune system allows leukocytes to access the entire body. And so in today's lecture, we'll be discussing some of the dynamics that are happening between the site of infection and the lymphatics. So the lymphatics are the drainage tubes that will then get filtered through the lymph nodes. And so, for example, if you have a fungal infection in your foot, what's going to happen is that the lymphocytes in the lymph nodes, the popliteal lymph node in this case, will be able to sense this and understand what's happening and what the pathogens are and where they're located. So we're going to discuss some of the basics of this in today's lecture. Specifically, we'll be talking about dendritic cells and how they get activated in the periphery, migrate into the tissues, and then into the lymphatics, and then can ride the lymphatics all the way to the local draining lymph nodes, and then understand the reactions that are occurring in those lymph nodes. In addition, we've talked about normal lymphocyte development. So we start with our hemopoietic stem cell, and then we can then differentiate down to all the different cells of the immune system. Today will be the introduction to the immunopharmacology, particularly around immuno-oncology. So we'll be talking about cancers. We'll have dedicated immuno-oncology lectures at the end of the course, but for now, we're going to be introducing these topics. So many different blood cells can be derived from the original pluripotent hemopoietic stem cell. And as we talked before, is that there's many different types of hemopoietic cancers. And so today we're going to be talking about BALL. So BALL. So in this case, the hemopoietic stem cell has begun to differentiate into your common lymphoid progenitor, and then it is started to turn into a B cell lineage. And then in this case, these B cells, as they're developing, there can be mutations, and this can give rise to your BALL, your B cell acute lymphoblastic leukemia. And so we'll be talking about this today, and we'll also be talking about this more in upcoming lectures in your upcoming homework assignment. So just to kind of introduce some core concepts as you do your reading. So the reading will be around the Brentgens et al. Paper. And so again, we've already seen the slide, but just a quick reminder is that these imaging and flow cytometry will be very important in order to understand the upcoming paper. So this again is a blood smear. So this is just a peripheral blood sample. It's placed on a cover slip and stained with pink dye, your eosin, and this purple dye, your hematoxylin. The hematoxylin is going to stain the nucleated cells, and the eosin is going to stain cytoplasm, in this case, your non-nucleated red blood cells. Here we can also see diagnostic BALL diagnosis, and so this is using flow cytometry. So flow cytometry, you can see this BALL expresses two common B cell markers. So this is CD10 and CD19. So these are markers that are expressed on all B cells, but normally B cells are at a pretty small percentage in the peripheral blood. So the B cells would be, maybe 5–10% of your total peripheral blood in a normal biopsy. But here we can see it's over 90%. So this is definitely indicative of cancer. This is definitely B cell acute lymphoblastic leukemia. And I know this because these cells express CD10 and CD19, the markers for B cells. And there's so many cells here that this is definitely going to be a B-ALL. And as such, we're going to target it with a targeted therapy. So in this targeted therapy would be CD19. So this is a really interesting, just fascinating paper. This is one of the first phase 1 clinical trials that was done using cellular therapies. So this is going to be adoptive cellular transfer of CD19 targeted T cells. And these CD19 targeted T cells rapidly induce remissions in adults with chemotherapy refractory acute lymphoblastic leukemia. So let's just talk about this and kind of walk through this title. So CD19 is a marker that's expressed on all B cells, but it's also a marker that's expressed on B-ALL, so the B cell acute lymphoblastic leukemias. So CD19 is expressed on the cancer, and you can see this in this patient here, is that 45% of the cells in this bone marrow biopsy are expressing both markers CD10 and CD19. And so these are T cells. These are engineered T cells. These T cells are designed to go out and kill CD19 or kill any cell that expresses CD19. So these cells, when they're transferred into patients, they induce molecular remissions. So what remission is remission means that you no longer see the cancer. So this patient right here, they have relapsed refractory cancer. And then after the treatment is you no longer see any CD19 positive cells. And as such is that this patient is now in remission. And so this remission is sustained. It's sustained out into day 24. And day 59, you can see there's a couple cells that are beginning to come back, a couple cancer cells that are beginning to come back. So chemotherapy refractory, what does chemotherapy refractory mean? Chemotherapy refractory means that these patients, here this patient MSK-ALL04, this patient was previously treated with chemotherapy. And that previous treatment with chemotherapy has now led that patient to not, this patient is resistant to that chemotherapy. This cancer is not being affected by that chemotherapy. So this is chemotherapy refractory ALL. So in this patient, ALL04, is that they've been blasted with lots of chemotherapy. Unfortunately, that cancer still persists. So this cancer is refractory to that chemotherapy. And it's really exciting when you have a patient that's totally refractory to the standards of care. You give them an experimental treatment, and then this causes a sustained and durable remission, molecular remission. So it's an exciting paper. It's really, in my opinion, a pivotal paper for the development of T-cell targeted therapies, targeted adoptive cellular therapies. And in addition, to understand how these cells work, these CD19 targeted T cells, in order to understand how these cells work, you really need to understand the context and the contents of this lecture. So let's get into the lecture, and I hope it's informative. So again, this is more of a review slide, but the 4 stages of infections, we have your local infection of the tissues, your lymphatic spread, and your adaptive immunity. So in all of these 4 different things is that there are extensive amounts of receptor-mediated signaling, migration, and transcriptional responses that are occurring throughout the immune response. And what I mean by that is that The receptors are the surface of the cells, is that these cells express receptors both on the surface where they can sample their environment, but also in their cytoplasm where they can sense what's happening inside their cell. And then using all this information, integrating all this knowledge from sensing it in your environment, now you can then make an educated decision what is going to happen to the fate of this inflammation. And what I mean by that is that within these cells, they have these this really specialized area called the nucleus. And that nucleus contains all of these weapons. And these weapons, these are genes, and these genes can be turned on or off depending on the signals that these cells are receiving from their environment and the receptors on their cell surface, on their plasma membrane, but also the receptors inside the cytoplasm. And with this, it can turn on genes, and these genes can do things like make cytokines. They can make certain molecules that allow these cells to migrate to the tissues. They can turn on certain chemokine receptors that allow these cells to migrate into the lymphatics and then ultimately to the lymph node. They can cause the expression of different molecules that are important for facilitating the different interactions that drive the immune response in the lymph node. They can also be important for turning on things like antibodies and antibody production and this adaptive immunity that'll help us get rid of the pathogens. So this receptor-mediated signaling, it's kind of, it feels a little boring in some ways because it's just a lot of kinase cascades and transcriptional activation and transcription factors. So a lot of basic biochemistry and molecular biology, but this stuff is so important because all of these things are so active during the immune response, and all of these things are drugged when you have overactive immune system. They're also drugged when you have a hyporeactive immune system, an immune system that's not killing pathogens the way it should, or in certain cases, not killing cancers the way it should. So receptor-mediated signaling is required for all cells and stages of the immune response. So these are just two of our initial responding cells, or macrophages. Macrophages hang out in the tissues. So macrophages are typically tissue resident. So for example, in the case of my fungal infection in the foot, I have all these different receptors, and these receptors are good at identifying what's going on in the local environment. For example, mannose receptor, some of these fungi might have repeats of mannose sugar on their cell surface. So this macrophage can use that mannose receptor to identify these pathogens because human cells don't have those repeated mannose on their cell surface. So we can discriminate self from non-self. And that's what these receptors are doing, allowing us to discriminate self versus non-self. So stage one is that this inflammation can be triggered through a variety of microbial stimuli. So we have our pathogen-associated molecular patterns, or PAMPs, but also DAMPs, or damage-associated molecular patterns. And what I mean by this is that things that are not supposed to be in the environment, if they are detected in the environment, things like nuclear proteins, like histones. Histones are typically hidden inside the nucleus. But what happens is that histones, if a cell is dying or a number of cells are dying because of a viral infection or something like that, is that those histones might spill into the environment, and some of these receptors can sense those histones and start inducing inflammation due to those damage-associated molecules. And then also we have our mannose, our lipopolysaccharide, all of our pathogen-associated molecules. Here we also have MAMs. These are our microbial-associated molecular patterns. These are activating things like toll-like receptors or a variety of other receptors that are expressed on dendritic cells. So dendritic cells are also resident in the peripheral tissues, and they can encounter pathogens and be activated by these microbial-associated molecules. So once the macrophage here encounters the bacteria or the fungus, what's going to happen is that it's going to go in and it's going to turn on transcription in its nucleus and start making molecules. Some of the initial molecules that are made are these molecules called chemokines and cytokines. So chemokines and cytokines are going to drive inflammation, local inflammation. And that's going to follow this immune receptor engagement. So what happens is that these receptors that are now no longer highlighted and labeled, but they're still there, these receptors are going to identify the microbes. And then from there, you're going to bring these into the cell, and that's going to allow you to understand what's going on in your local environment. That there's bacteria and pathogens or fungus in the local environment, and that's going to activate transcription in the nucleus, and you're going to get production of pro-inflammatory molecules like cytokines and chemokines. These cytokines will cause the endothelium to vasodilate and make adhesion molecules. So essentially what happens is that these cytokines are going to bind to cytokine receptors on the local vasculature, the local endothelium, and that's going to change the transcriptional state of the endothelium. The endothelium is going to become inflammatory. And what I mean by that is it's going to downregulate expression of those tight junctions that prevent cells and other things from leaking into the tissues. And it's going to induce expression of things like cellular adhesion molecules, these ICAMs and VCAMs. And these cellular adhesion molecules are going to be sticky. So you're vasodilating, you're also permeabilizing, so making, getting rid of the tight junctions, and you're also making this vasculature, you're making it sticky. And as such, that vasodilation, that increased vascular permeability are going to cause that redness, heat, and swelling. So what do I mean by that? Is that by causing a disruption in those tight junctions, now you're having fluids come in. You're also having these neutrophils come in, and the reason these neutrophils and other immune cells can come in is because of those adhesion molecules that are now expressed on the endothelium. Those are coming in. We also have other blood cells that are making it in, and this vasodilation is going to cause more and more blood in that local area. So you're getting the redness from the increased amount of red blood cells in the area. You're also getting swelling because of the accumulation of fluid inside the area because of that leaky vasculature. You're also getting swelling because more and more immune cells are leaving the blood system and are entering the local tissues. You're also getting heat because all of these transcriptional responses, these are very energy intensive. You're burning a lot of ATP to do all that transcription and translation. And as such, what you're doing is you're boosting up the metabolism, that boost of the metabolism, and more cells in there doing a lot of metabolism. Then one of the byproducts of metabolism is heat. Eventually, the inflammatory cells migrate into the tissue, releasing additional inflammatory mediators that will cause pain. So in addition to your local inflammatory responses that are ongoing, you also need to call in the big guns, because hopefully the local innate cells, the monocytes, neutrophils, macrophages, hopefully they can clear it all out on their own, no big deal. But just in case, you need to let the adaptive immune system know what's happening. The adaptive immune system has those really strong effector molecules that can really induce strong inflammation. Things like very potent interleukins, things like antibodies secreted by B cells and plasma cells, things like perforin and granzyme that are highly cytotoxic that are made by activated T cells. So in the tissue, you have these immature dendritic cells, but once they get activated through the receptors on their surface, they're going to start to change their transcription, and they're going to start to upregulate different molecules that help them migrate, including chemokine receptors. Those chemokine receptors will cause chemotaxis, where these cells will start migrating into the lymphatics, and then from the lymphatic vessels, they'll migrate all the way to the lymph nodes. Why do they migrate to the lymph nodes? It's because the lymph nodes are continuously expressing different chemotactic molecules like chemokines. And because now the activated dendritic cells have those chemokine receptors, the cells are going to migrate towards the source of the chemokine, make its way into the lymph node, and then they're going to start activating the T cells. Activating those T cells in the lymph node will then cause these T cells to become very active, very inflammatory, and those T cells can then migrate back out to the tissues. So dendritic cells and lymphatic drainage enlist the local lymph nodes and are going to cause activation of the adaptive immune system. So components of each stage of this activation are immunosuppressive therapeutic targets. So here's a table from Janeway. You see these are all the conventional immunosuppressive drugs in clinical use. So in particular, these first 4 rows, corticosteroids, your antimetabolites, your calcineurin inhibitors and mTOR inhibitors, all of these are old drugs. These are what's called your first-line therapies. The reason these are your first-line therapies are because they work. They work very well to tap down inflammation. And we'll go through the mechanisms on how these things work later in today's lecture. But these are highly effective molecules, and they work, and then also very importantly is they're also very cheap. So these are all generic. These are older drugs that were discovered decades or even centuries ago. These are very old drugs, and as such, they're no longer on patent. They can be prescribed very cheaply, very easily. And all of these in the table, these are also small molecules. So because they're small molecules, because they're made in a organic chemistry lab, for lack of a better term, these molecules are orally taken, or they can be topically taken, and they have great shelf life, easy to store, and they're very effective at shutting down inflammation. So first we have our corticosteroids. These are also called glucocorticoids. These potently inhibit inflammation. We also have our antimetabolites, aka cytotoxic agents, like thiopurines, CellCept right here, mycophenolate. So what these do is these are interfering with DNA synthesis. And so the idea here is that as these immune cells are expanding and dividing and rapidly proliferating, by blocking DNA synthesis, is that you can interfere with the replication of the immune cells, and as such, you'll have less inflammation because there's just less immune cells. So these are very effective and they work great, but these are also cytotoxic agents. So these can also have off-target effects, and these are also very similar, and some are actually the same drugs that can be used in certain chemotherapy regimens for oncology purposes. We also have calcineurin inhibitors. So calcineurin inhibitors will block activation of our calcium signaling, and then this will then block our nuclear factor of activated T cells, shutting down cytokine production like interleukin-2, shutting T cell proliferation and division. We'll talk about this less, but there's also rapamycin. Rapamycin inhibits T cells. So this is an mTOR inhibitor, mammalian target of rapamycin is right here. And then this is a newer drug. We'll talk about S1P1 modulators in a lot more detail in the second half of this class. Okay, so let's start with NF-kappa B. So inflammatory signaling will send inflammatory transcription factor NF-kappa B to the nucleus. So almost every cell in your body expresses NF-kappa B. And so NF-kappa B is driving inflammatory processes. So if we look at the case of our fungal or bacterial infection in the foot, what we're having toll-like receptors that are going to be driving NF-kappa B into the nucleus. If you go to Janeway's immunobiology, they go into a ton of detail about the different NF-kappa B, canonical, non-canonical. For the purposes of this class, we just need to know that NF-kappa B is the master driver of inflammation. NF-kappa B is going to activate NF-kappa B responsive genes. So in the case of our macrophage, that macrophage is going to see the bug, it's going to activate NF-kappa B, and it's going to make chemokines and cytokines and other cytolytic molecules. In the case of our local endotheliums, the blood vessels, those blood vessels are going to sense the cytokines. They're going to sense the cytokines made by the macrophages through their cytokine receptors. Here we see a tumor necrosis factor receptor, interleukin-1 receptor. What that's going to do is that's going to activate NF-kappa B in the endothelium. And that endothelium is then going to send NF-kappa B to the nucleus, and then it's going to change expression of things like adhesion molecules that are going to help drive that inflammatory process. NF-kappa B won a Nobel Prize for this discovery a couple decades ago now, but this stands for nuclear factor kappa light chain enhancer of activated B cells. You don't need to know this, but just know that NF-kappa B, master regulator of inflammation, very important for driving inflammatory responses in almost all cell types. So typically, these transcription factors, these inflammatory transcription factors, are constrained in the cytoplasm. Why do you keep transcription factors in the cytoplasm? It's because in the cytoplasm, there's no DNA. So these transcription factors have nothing to bind to. They're just sitting there waiting in case you need them, in case there's inflammation or a pathogen or a microbe. What's going to happen is that's going to activate the NF-kappa B, send it into the nucleus, and now you're going to get activation and transcription and translation of NF-kappa B responsive genes. So in the case of immunopharmacology, this is important because corticosteroids block NF-kappa B transcription. So these are several different types of anti-inflammatory drugs. So these are all derived from cortisol. Cortisol is a naturally occurring molecule. It's your stress hormone. It's very important in stress responses. Your adrenal glands will make cortisol. And what's going to happen is that cortisol will suppress the immune system, suppress inflammation. The drug name of cortisol is hydrocortisone, but there's also a variety of other variants through the magic of medicinal chemistry. Is we've taken this cortisol, added extra double bonds here, and made a double bonds here. So just very slight modifications. But what this does is this turns this into prednisone, which has slightly different pharmacology, can be useful for certain situations. Dexamethasone, even more potent, having this fluorine and this extra methyl group here to help with the pharmacokinetics and the activity on the glucocorticoid receptors. So all of these drugs, we're not going to go into a ton of detail in this class. That will come at a later time. We don't know exactly what steroid we're going to prescribe in exactly what situation. But in this case, we just need to know that all of these corticosteroids, anything that ends in the "-sone" or "-lone" suffix, is going to be your corticosteroids. And these are going to be blocking NF-kappa B transcription to stop inflammation. So these corticosteroids are common first-line immunosuppressive therapies. So these corticosteroids, they have great effects on shutting down cytokines, including interleukins, tumor necrosis factors, granulocyte monocyte colony stimulating factors, chemokines. So all of this, by blocking that, that's going to cause a reduction in inflammation caused by the cytokines. It'll have reactions on our nitric oxide synthesis. That means we're going to be making less nitric oxide. It's going to be shutting down different things like phospholipase A and cyclooxygenases. This will then cause a drop in other inflammatory lipids, things like prostaglandins and leukotrienes. These are major effectors that are going to cause things like pain. We also have adhesion molecules, drop in adhesion molecules that will cause less inflammation because we're getting less emigration of leukocytes from the vessels. And it's going to increase expression of endonucleases. That's going to help drive death of some of our immune cells. So these corticosteroids are working by numerous inflammatory mechanisms, but these corticosteroids have broad systemic activity. As we know, is that glucocorticoid receptors are expressed on every cell in your body. So if you're dosing high amounts of corticosteroids for a long time, there's so many risks associated with this as far as chronic adaptations, things like adrenal atrophy in particular, but then other things that we'll talk about a little later. So because these corticosteroids have broad systemic effects, they're not always favored for long-term systemic use. So these are typically confined to things like acute dosing when you want to shut down inflammation quickly. And we'll see that in the upcoming homework assignment, the paper that we're reading. Also topical dosing. So for example, a lot of creams, a lot of eye drops are used for topical dosing. Even in certain inflammatory bowel disorders, you might have a particular corticosteroid called budesonide. Budesonide has a certain metabolic trick built into it. So when it's taken orally, it's rapidly metabolized by the liver. This way it can kind of coat the gastrointestinal tract and then be eliminated by that first pass metabolism, be metabolized in the liver as it's getting absorbed through the gut into the portal vein, and therefore it's going to limit its systemic bioavailability. So therefore you're getting less systemic effects. So this is one trick to do these medicinal chemistry modifications to limit systemic activity. However, there are certain situations, for example, transplant immunology, where these patients will be on corticosteroids every day for the rest of their lives because you'd rather manage the symptoms associated with long-term corticosteroid use, things like adrenal atrophy, things like risk of developing Cushing's disease. You'll manage all that because you can live with those, but you can't live if you have a rejected kidney, for example, in the case of kidney transplant. So corticosteroids, wonderful drugs, magic drugs, and they're quite effective. So those are our steroids. Now we'll take a pivot and talk about non-steroidal anti-inflammatory drugs, or NSAIDs. So NSAIDs are less potent than steroids, but they're common first-line immune targeting agents. So non-steroidal anti-inflammatory drugs, NSAIDs, are less potent than steroids, but again, these are also very commonly prescribed. So these are your inflammatory lipids. So in your plasma membrane, you have your phospholipids that make up the membrane, but there's an enzyme called phospholipase A that can start cutting up those membranes and using those lipids and start driving them down these paths and making things like prostaglandins. And what's going to happen is that these prostaglandins are inflammatory lipids that can have a variety of effects on the local tissues, on the vascular endothelium, on the nerves, and then a number of other activities. So these arachidonic acid, for example, arachidonic acid will be metabolized by your cyclooxygenase enzymes, COX-1 and 2, into all of these different prostaglandins, and then you have these tissue-specific enzymes that can make these into a variety of different prostaglandins. For the purpose of this class, we're not going to have to memorize all of these prostaglandins. If there's a key prostaglandin that you need to know, it will be on the study guide, so look on the study guide for those. But essentially these NSAIDs, these non-steroidal anti-inflammatory drugs, these are COX inhibitors. So the NSAIDs work by suppressing prostaglandin synthetases 1 and 2 that are also colloquially known as cyclooxygenase 1 and cyclooxygenase 2. So these enzymes are producing prostaglandins, and these lipids can trigger pain and fever. So COX-2 produces most of the prostaglandins that are relevant to pain and inflammation. So NSAIDs can be selective, or they can have dual activity. So NSAIDs like So NSAIDs can be selected for inhibiting COX-2, including these two NSAIDs right here. Ibuprofen is really your most common one. It's an NSAID that blocks both COXs. Okay, so just reviewing this previous slide. So your dendritic cells get activated, they migrate to the lymph node, and then they're going to present antigen to your T cells. So now we're going to really hone in on this T cell activation, because T cells are the most inflammatory cells in your body. So we're really going to hone in and look at what's happening with this T cell activation. So activated dendritic cells are making a variety of different molecules. So they're making CCR7. CCR7 is going to be that chemokine receptor that'll drag them to the T cell area of the lymph node. It'll make things like MHC class 2. MHC class 2 is a key molecule in antigen presentation. It's going to be very important for interacting with these T cells. Also, your B7 molecules, CD80 and 86, and inflammatory or inflammatory, or in some cases anti-inflammatory cytokines. So in this case, activated dendritic cells are making a ton of molecules, and these molecules are all very important on getting them to where they need to go and then interacting with the cells they need to interact with. So antigen presenting cells are presenting 3 different signals to T cells. So one is going to be your activation signal, and this is antigen presenting cell APC on the top. So we have MHC class 2, MHC class 2 in yellow, and then the red is the pathogen associated antigen. So an antigen is just a little bit of a pathogen. So something that the T cell will understand is non-self, or in this case, the T cell is going to become active in the case of this antigen presentation in this pro-inflammatory context. So on the T cell, you have the T cell receptor. The T cell receptor recognizes the antigen and presented in the context of MHC class 2. This interaction will be stabilized by a molecule called CD4. Then you have your B7 molecules, B7.1, B7.2, interacting with CD28. This is your survival co-stimulatory signal that's going to further activate the T cell. And then you're going to have your cytokines, all your different interleukins here. We'll cover all these in much greater detail at a later point in the class. But we have the antigen presenting cells secreting a number of these cytokines that will cause differentiation of the T cell. So the antigen presenting cell, these activating dendritic cells will serve as APCs, and this will properly activate our T cells through 3 signals. Your activation signal with the antigen in the context of MHC class 2 presenting to the T cell receptor. You have our co-stimulatory signal that's driven by B7, also called CD80 and 86, on the surface of the antigen presenting cell, and to the binding to CD28 or CTLA4 on the surface of the T cell, and then our differentiation signal 3 that's driven by the cytokines made from the antigen presenting cell binding to the cytokine receptors on the T cell. So this is an image that was made in the School of Medicine in Irvine Hall a couple decades ago, but let's just watch this. So this is a T cell. This is going to be a movie. This is an antigen-specific T cell. And on the surface here, you have an antigen-presenting cell. In this case, it's an antigen-presenting B cell. Let's just watch their interactions. So this is the immunological synapse that's being formed. So essentially what's happening is that all of those receptors and all of those molecules that we discussed on the previous slide, all of those are going to be now going to be focused and the interface between the T cell and the antigen presenting cell. So if we watch this happening, you can see that as the T cell interacts with the antigen presenting cell, the T cell is expanding its membrane and it's almost engulfing that B cell. And then what's going to happen is that as the surface, as the plasma membrane of these 2 cells are interacting and kissing, is that now you have interaction between all the molecules on the antigen presenting cell, like MHC class 2, excuse me, and then also all the molecules on the surface of the T cell, things like your T cell receptor, your CD28. What's happening is that all of these are finding their binding partners. And then as the reaction occurs over time, is that that interface begins to reduce. And now you have this synapse, this small site between the two different cell types. And all of these molecules, all of these receptors are now focused onto a single site. And a clustering of those things together is going to activate this T cell in a way that this T cell is going to go from naive and not doing anything to now becoming very pro-inflammatory and competent to kill off the pathogen. So when the T cells encounter the MHC, this T cell receptor clustering will occur, forming this immunological synapse. But as you notice, that's not the only thing happening here. This cell is loaded with what's called a calcium indicator dye. So this is a fluorescent dye, and it's going to change color depending on the calcium levels inside that cell. So let's look at this. When the calcium signal is blue, that means that it's low calcium. Things like, nanomolar calcium inside the cell. But when it turns green and yellow, that means that the calcium levels are higher inside the cell. So watch this. So purple, low calcium, interacts with this. And the first thing that happens is you get this massive influx of calcium. That massive influx of calcium is driving the calcium into the cell. So you're going from nanomolar concentration of calcium in the cell and boosting that up to micromolar concentration. So you're having all this calcium flood into the cell. And this is one of the first reactions that occurs. What does calcium do? We know that calcium is a very sticky ion. Calcium in solution likes to cause precipitation of things. So what's happening is this T cell is migrating around, but when it encounters its cognate antigen presented by the antigen presenting cell, this T cell is going to get a flood of calcium, and that calcium is going to stop it from migrating. That calcium is going to help it stabilize and cause a sustained interaction with that antigen presenting cell. And then also calcium is going to bind to calcium dependent proteins inside the T cell. And that calcium is also going to activate calcium dependent transcription factors inside that T cell. So this dynamic interaction is so important for clustering all of those molecules from the previous slide, and then also driving calcium into the cell that's going to facilitate that activation of the T cell. So pro-inflammatory signaling cascades are complex, but therapeutically important. So when we have this T cell receptor complex binding to MHC class 2, an antigen presented in the context of MHC class 2, so many things are happening. Oh my gosh, this is such a complicated slide. We don't have to understand all of this, but understand that what's happening is that we're getting activation, and we're turning on a variety of different things. First thing that we're going to turn on is this NF-kappa B. Again, NF-kappa B is our master pro-inflammatory transcription factor. We're also going to activate these calcium pathways. Calcium right here. Calcium is going to then drive activation of calcineurin and the transcription factor NFAT, nuclear factor of activated T cells, NFAT. That's NFAT and NF-kappa B are going to be driving inflammation in the cells. So we have our T cell receptor, which is going to be that immune receptor on the surface of the T cell. We have our CD4. CD4 is going to stabilize that immunological synapse. We also have these signal initiators. These are called CD3. These are going to activate a variety of kinases. CD3. And then what's going to happen is that these kinase cascades and phospholipase cascades, these are then going to cause divergent signaling in the cytoplasm. So it means we're going to activate calcium-dependent pathways like this, things that we can shut down with our calcineurin inhibitors. So this is the drug target of our calcineurin inhibitors. We're blocking that calcium release. We're blocking that calcium influx. We're blocking the calcium signaling and the NFAT activation. We also have other pathways, in particular, this NF-kappa B pathway, and this is going to cause activation of NF-kappa B, and we can block this with corticosteroids. We also have another process called the MAP kinase process, activation of the AP1 transcription factor. But because we can't drug that, right now there's no drug to block AP1, we're not going to talk about that for this class. It's less relevant. We don't need to know everything, but we definitely needed to know the pieces that are drugged and are important for immunosuppression in a clinical setting. So we see these signals diverge in the cytoplasm, and then they're going to converge on the nucleus. What's the deal with that? Why do we need this, single receptor up here, and then we get this divergent signaling activating all sorts of transcription factors, and then all these things are converging back into the nucleus to drive cell proliferation and differentiation? Why can't we just do one process? And the reason for having these divergent and convergent pathways is that these are checkpoints. Is we want to make sure that because these T cells are so powerful, so inflammatory, if the T cells go haywire, we're going to develop an autoimmune disease. We're going to have unwanted inflammation. So these are just kind of checks and balances. Let's make sure that it's very complicated so that every step needs to get turned on in sequence. And if it doesn't happen the way it's supposed to, we're not going to turn it on. We just want to be safe and make sure that we're turning on inflammation when we want to turn on inflammation. Because if we don't turn on inflammation at the right time, that can have unwanted inflammatory effects in the body. That's no good for anybody. So let's talk about this calcium regulation. So we have NFAT, the nuclear factor of activated T cells. So what happens is that just like everything else, all the other transcription factors, NFAT hangs out in the cytoplasm, and NFAT's just waiting for a signal. And then what happens is these calcium channels open. They're called calcium release activated calcium channels, crack channels. These calcium channels are going to open in response to T cell receptor activation. What that's going to do is that's going to turn on NFAT, turn on calmodulin, turn on calcineurin. They're going to form this complex. That complex is going to dephosphorylate NFAT. These little purple blobs are phosphate groups on the NFAT that's keeping it in the cytoplasm. You're going to dephosphorylate it. It goes into the nucleus. It's going to turn on gene transcription. You're going to start getting inflammation. So calcium signaling pathways are good targets for immunosuppression. So calcineurin inhibitors prevent inflammation. Cyclosporin, tacrolimus, pimcrolimus, these are your prototypical calcineurin inhibitors. So these are used systemically in combination with corticosteroids and antimetabolites in organ transplant. And they're also used topically in ophthalmology. They're used for conjunctivitis. In dermatology, these are used topically for atopic dermatitis. And here, this is kind of their mechanism. This is their structure and their mechanism of action. Is that these molecules, they're going to be binding to what we see here, and they're going to be preventing this NFAT they're going to prevent the dephosphorylation of NFAT, keeping it in the cytoplasm. Therefore, you're not getting NFAT into the nucleus. You're not getting the inflammation that's driven by this. And again, when you use it in combination with corticosteroids, this is very potent, blocking both the NFAT and the NF-kappa B, really shutting down that T cell inflammation. The reason that these are not typically used for long-term systemically, again, you can in the case of transplant biology and other certain situations. However, it's a lot of monitoring are required because calcineurin is expressed by a large number of cells. Many different cells in the body express calcineurin, not just your T cells. And so therefore, these are associated with renovascular side effects. So in the kidneys, this might be associated with renovascular hypertension, for example. So this is definitely too much information, but I'm just going to use myself as a case study. So this is from the beginning of the pandemic, we started wearing these masks every day, and my skin just flared up, and I had this massive reaction to wearing the masks. And essentially, I couldn't interact with dermatologists because all the derm clinics were closed, and it was months wait to get seen by somebody. And so essentially what I developed is a skin condition, an inflammatory skin condition called seborrheic dermatitis. And so seborrheic dermatitis, you can kind of see it. It first started on my nose, and then it just continued to progress as I wore more and more masks. It just progressed to multiple sides of my face, progressed to my forehead. So this is a common skin condition that mainly affects the face and the scalp. So the sebaceous glands are located on this area of the face. These sebaceous glands make a lot of the oils. And so essentially this mask wearing triggered something in my skin immune system. And what happened is that I developed this massive seborrheic dermatitis. And I got on the phone with telemedicine with a PA who prescribed some antibiotics, topical antibiotics that really didn't do anything. So it wasn't until I saw an actual dermatologist, this dermatologist recommended Elidel. Elidel is a calcineurin inhibitor. So calcineurin inhibitors, I still use them day to day, and you can see that they work great for me. And so essentially what these calcineurin inhibitors are doing is they're applied topically, they go into my skin, they block NFAT activation in the T cells, and as such, I'm not getting that red, patchy, scaly inflammation that I had. I also, in order to tap down that original big kind of swelling, and you can see it's definitely inflammation, right, with the redness and the swelling and the pain, is that shutting that down. I also used a little bit of corticosteroids, but corticosteroids are not used long term, and the reason you don't want to use topical corticosteroids long term is because normal keratinocyte proliferation and division in the skin uses some level of NF-kappa B transcription. And so if you're blocking that by applying a lot of corticosteroids chronically, topically for a long period of time, is that you're actually going to suppress your keratinocytes from dividing, and that will result in steroid-induced skin atrophy. So the skin will thin, and the reason the skin will thin is because there's less dividing keratinocytes. So fortunately, calcineurin inhibitors aren't blocking that process, and so calcineurin inhibitors can be used chronically, where steroids, it's better to use those acutely to shut down inflammation, but not take those long term. Okay, so these calcineurin inhibitors block calcium-dependent inflammatory processes. So this cyclosporin A, tacrolimus, also pimcrolimus. So we have effects on T cells. So again, all these are important for shutting down NFAT. So we're reducing expression of interleukin 2, 3, 4, tumor necrosis factor alpha, reducing proliferation, causing reduced calcium-dependent exocytosis of granule-associated serine esterases, inhibition of antigen-driven apoptosis. So essentially, calcium is very important for fusion of granules to membranes. So by blocking this calcium processes, you're blocking not only transcription, but a number of other processes also some effects on B cells, also some effects on granulocytes as well. So immunophilins are the drug targets of calcineurin inhibitors. So these are calcineurin in particular. Calcineurin and NFAT are broadly expressed, but you also are, again, you don't want to. So even though these are so important for driving inflammation in your T cells, granulocytes, and a little bit in B cells, again, you don't want to use them chronically if you can avoid it. Sometimes you need to in the case of transplant, but sometimes you want to avoid this. And the reason is because you can get calcineurin inhibitor-induced nephrotoxicity. And so essentially this works because the afferent arterioles that are going to the kidney also express calcineurin, and this can cause vasoconstriction, lowered renal blood flow, also causing ischemia in the kidney and a lowered filtration rate in the kidney. So let's look in the case of transplant immunology. It's a very interesting case. It's a very recent case, actually. And this was actually the first described face transplant in a Black man. So I want to use face transplant as a case study. And we're going to talk about management and racial considerations in this case. So yeah, it's just fascinating read if you want to read it down here, is that, there really never been described a face transplant in a Black man before in the literature. So this is published in the New England Journal. But so this man on the left and on the right, I guess, 67-year-old man had a motor vehicle accident and had pretty severe burns across his face. So patient B, or panel B, is after the face transplant. So the donor was a 61-year-old Black man who met the criteria for brain death and had physical characteristics and skin tone that were similar to those of the recipient. So it wasn't a perfect match, but no match is going to be perfect in transplant immunology. Even if the major histocompatibility is in place, there's still going to be minor histocompatibility. In this case, there were 4 HLA. This is your MHC, your major histocompatibility mismatches. HLA is the human leukocyte antigen. This is just another name for MHC in humans, HLA, A1, B2, and DR1. And for this patient, he was prescribed CellStep, myclophenolate, an anti-metabolite, tacrolimus. Tacrolimus, again, being our calcineurin inhibitor, and prednisone being a steroid, maintenance immunosuppression. So this patient will be on these immunosuppressive drugs for the rest of his life, but it's, fine, and just monitor. It's going to be a lot of monitoring this patient, mixing up the immunosuppressive strategies depending on if there's some rejection or if those immunosuppressive agents are not well tolerated or lead to severe adverse events. But it's just interesting that the skin tone was accounted for, and I highly encourage you to just read the article if you're curious. Okay, so now that was all signal 1. We were talking about steroids and calcineurin inhibitors. Now let's talk about signal 2. So signal 2 is CD28. So CD28 on the T cell will bind to B7. B7-1 is called CD80. B7-2 is called CD86. Why do we have multiple names for the same thing? It's just the alphabet soup that is immunology, is that these things were discovered at the same time by different groups. And so different groups kept calling them the same thing or different things. And so as such, we just have to be aware that there's multiple names. So one dimer of CD28 engages one dimer of B7. So CD28 is on the T cell, B7 is on the antigen presenting cell. So these T cells require 3 signals to be fully activated. What this survival signal is going to do is it's really going to turbocharge this activation signal 1. So these signals are going to combine to really drive that pro-inflammatory signaling. And then this process here can also be modulated therapeutically. So what we'll have here is signal 2 is CD28 on the T cell binding to B7 on the antigen presenting cell. So signal 2 will combine with signal 1 to activate these T cells. So T cell receptor is going to activate a variety of kinases and phospholipases. And then this will activate things like our NFAT. CD28 is also going to help this. And so essentially you're getting all these pro-inflammatory signaling, these pro-inflammatory transcription factors like NFAT, NF-kappa B, AP1, all of these are going to converge on this gene region. This gene region is called the promoter region. So essentially these are going to bind to the promoter and it's going to recruit an enzyme called RNA polymerase. RNA polymerase is going to transcribe pro-inflammatory genes like IL-2, and IL-2 will be a positive regulator of inflammation. And we're also going to get activation of other things like CTLA-4, where CTLA-4 is going to be our negative regulator of inflammation. So major immune transcription factors are going to be converging on immune promoters like IL-2, CTLA-4, and that's going to enable gene transcription. So let's talk about this negative regulator, this immune checkpoint. So anything in physiology, when I turn it on, I also have to have a way to turn it off. And one of the ways to turn off T cells is this molecule CTLA-4. So what's going to happen is that B7 and CD28 are going to interact to drive inflammation. But then the T cell is going to understand, hey, I'm really inflammatory now. I could cause a lot of damage. So I'm going to turn on the off switch. I'm going to make CTLA-4. What CTLA-4 is going to do, CTLA-4 is going to bind to B7 with a much higher affinity. And that is then going to prevent this interaction on the left, favoring this interaction on the right. So in a naive cell that's getting activated for the first time, this interaction here is the only interaction that can happen because CTLA-4 is not there. But once the cell is turned on, it's going to make molecules. One of the molecules is going to make a CTLA-4, and that CTLA-4 is going to act as an immune checkpoint, pumping the brakes, preventing too much inflammation that could be harmful to the individual. So CTLA-4 stands for cytotoxic T lymphocyte-associated protein 4. So CTLA-4 on T cells blocks this signal to preventing T cell activation. So why is this important? The reason this is important is because this has been therapeutically changed, therapeutically intervened through different drugs. In particular, this wonderful immuno-oncology agent called ipilimumab. Ipilimumab, its trade name is Yervoy, blocks CTLA-4 and promotes T cell activation. So let's take a look at this. So in this case here, this is taken from Bristol Myers Squibb, who markets ipilimumab. And so ipilimumab, you can see it here, is that this is a disease called metastatic melanoma. So this patient here is not in good shape. This patient has severe metastatic melanoma that is likely spread through the entire body. You can see the lesions in the skin. This patient is likely refractory to chemotherapies. And so what's happening here is that how do you kill this cancer? So some of the old school methods that are still tried and true and commonly used are direct cytotoxic agents that can kill cancers, things like chemotherapies and radiation, things that can kill off the cancer directly. But thanks to the discovery of ipilimumab and other immune checkpoint inhibitor immunotherapies, we can now activate the immune system, cause inflammation. How are we going to cause this inflammation? Is we block the negative regulator switch. So in this case, there's a lot of CTLA-4. Why is there a lot of CTLA-4? It's because the cancer doesn't want the immune system to kill it. The cancer wants to survive. And so it's going to turn off the immune system by using a lot of CTLA-4 to shut down inflammation. Here, what we're doing is we're blocking that inflammation, we're blocking that negative regulator. We're blocking CTLA-4 with IPI, and IPI, when it's administered 12 days after administration, you can see these lesions are really starting to swell. That's not good, or is it good? So essentially you don't want your cancer to grow. Cancer growing isn't good. But actually, if you look in closely, that's not what's happening here, is that the cancer is not growing. The lesions are getting bigger. The lesions are getting bigger because of inflammation. Is that by blocking that CTLA-4, by blocking that immune checkpoint, by blocking that negative regulator, now I'm getting way, way more inflammation. I'm getting swelling, I'm getting redness. You can see the swelling, you can see the redness, I'm getting heat, I'm getting pain, and all of that is really good. It's that we're causing inflammation. Inflammation can kill the cancer. It's called, what we call it here, a pseudo-progression. It looks like it's progressing because the tumors are getting bigger, but it's not true progression. It's a pseudo-progression that's driven by inflammation. So you can see week 14, the lesions are now getting smaller. Week 72, complete remission, no visible cancer. And that is sustained out, years after the initial therapy, is that this patient was going to die due to his cancer. And now that cancer is gone because we identified these immune checkpoints that negatively regulate the immune response. And we block that, inducing inflammation. So ipilimumab drives inflammation by blocking the checkpoint. As such, we can kill the cancer by harnessing the power of our own immune systems. It's pretty awesome. So the way this works is that normally the T cells get activated by the T cell receptor, recognizing antigen in the context of MHC class 2. And they also need this co-stimulatory signal, the survival signal driven by CD80 and 86, the B7 molecules on the antigen presenting cell, and CD28 on the T cell. But what's going to happen is that's going to cause activation and transcription and translation of a molecule called CTLA-4, where CTLA-4 is going to compete and outcompete CD28 to shut down this process. And so essentially this CTLA-4 has now mopped up all the CD86, and that's going to inhibit the T cell preventing inflammation. Here though, with Yervoy, with ipilimumab, Ipi has such a high affinity for CTLA-4, it's going to steal it away from all the CD80-86. That's going to give the CD28 its opportunity to interact again. And that's going to cause the T cell to become active again, driving inflammation and killing that melanoma. So we have these other immune checkpoints that we know about, things like PD-1 and others being researched, and other immune checkpoint inhibitors. We have nivolumab, its trade name is Opdivo, that's approved for lung, skin, kidney cancer. We have pembrolizumab, marketed as Keytruda, that's great for lung and skin cancers. And there's so many oncology trials currently undergoing different testing with these agents, as well as other immune checkpoint agents. So with that, now let's take a little pivot through our immuno-oncology and talk about the development of chimeric antigen receptors to target cancer antigens. So in this case, and I'll go through this in more detail on a subsequent lecture, but essentially what we have here is we have these chimeric antigen receptors. So these are not natural receptors. These are receptors that have been made in a lab. And essentially what they're doing is they're combining CD28 and CD3, so our pro-inflammatory signals that are driven by that signal 1, activating the T cell receptor in CD3, and then our CD28, which is that survival co-stimulatory signal, fusing them together and then putting them into a T cell. And then what that's going to do is that's going to cause activation of all these signal intermediates, but ultimately activation of NFAT and NF-kappa B. And that's going to cause massive amounts of proliferation, survival, and cytokine production to help kill cancer. And so our upcoming quiz is going to be using these T cells and understanding our knowledge of NFAT and an F-kappa B to see how these engineered T cells can kill cancer. And so the way this clinical trial works, this chimeric antigen receptor clinical trial works, is that these T cells are taken from the patient. So these T cells are taken directly from the patient, from their peripheral blood. The CD3 positive T cells are harvested, isolated, and then they're introduced with this chimeric antigen receptor DNA. This DNA goes into the nucleus, and this chimeric antigen receptor gets transcribed and expressed. And now these T cells that you took away from the patient, now these T cells are supercharged with this chimeric antigen receptor. And now these T cells that have been manufactured to produce this unique cancer-killing receptor are now reintroduced back into the patient. And we'll see as we read through this paper how these things are killing off the cancer. It says patient monitoring, we'll be looking at bone marrow biopsies, peripheral blood flow cytometry, and we'll be looking at the chimeric antigen receptor T cells and how they're functioning in this patient. So I hope you enjoy reading the article. It's really a fascinating article. Thank you so much for your time, and I look forward to the other upcoming lectures.